everyone. Welcome. I think we've got about 20 participants and it's 11:03, so we're going to go ahead and get started. Thank you all so much for joining. We are very excited to kick off our Passport series, in which different speakers from across the globe are going to be talking about their respective organizations with regards to reproductive rights and access, as well as environmental sustainability. Today we have Dr. Michelle Dubon of Wings Guatemala, who is going to be leading a discussion on the state of reproductive rights throughout Guatemala and perhaps Central America. And so just to give you an idea of the structure of this panel, I'm going to give a quick intro and bio for Dr. Dubon, who's the medical director of Wings. Then Dr. Michelle Dubon is going to give a presentation on the state of reproductive rights, and then we're going to facilitate a Q&A afterwards. So if you do during the presentation have any questions that you would like discussed, please go ahead and submit them in the chat. We've got Stephanie and Natalie here, who are going to be helping to field questions and hopefully facilitate a really good discussion. Okay, I'm gonna go ahead and get started. Okay, so again, we've got Dr. Michelle Dubon here of Wings Guatemala. She's the medical director. Since 2015, Dr. Dubon has overseen all technical aspects of clinical services provided by Wings. She has been in practice since 2004 and has specialized in OB/GYN services since 2008. Along with providing administrative oversight, Dr. Dubon works with 3 other surgeons to provide tubal ligations and vasectomies, making Wings one of the few places in Guatemala that anyone over 18 can get a permanent surgical contraceptive operation without a partner's consent or proof of multiple children. Michelle was part of the 2019 class of the Aspen Institute New Voices Fellowship, a group of 25 leaders from the Global South who work on the front lines of global development and health. Dr. Dubon has also been instrumental in assuring that Wings meets the highest international standards of surgical healthcare. So again, thank you so much for being here, Michelle, and I'm going to kick it to you. We're excited for the presentation.
Thank you, and thank you for the opportunity to share my experience from Guatemala and for giving me this hour of your time to let me share all this experience that we have had. This is the last picture that we took of the whole team at Wings. It was March 12, 2020. And this is the beautiful team that makes reality happens. And I'm gonna tell you a little later a lot of things that we do. But first of all, I want to share with you a little bit of Guatemalan context. We have 17 million population. Women in reproductive age are 5 million, but there's a big but here. It's women from 15 to 49 years. But we have about 2,000 girls from 10 to 14 years giving birth every year in the country. So this is a bigger group of women that can be pregnant in our country. 15% of these women have referred that they experience some kind of sexual abuse in their lives. 5% of them have become pregnant, and only 30% have searched for some help with the police, with the hospital. So we have a lot of women suffering violence, sexual violence, and not searching for help, and that's a big issue in our country. A little bit of context about sexual and reproductive health. Guatemala has one of the highest teen pregnancies rates in Latin America and in the world. In Latin America, only Haiti we're after Haiti. And we're the only ones in America that instead of stopping this, we're in a rise. The average of the first birth is 20 years old. And in some places, in some villages, half of the teenagers are pregnant in this moment. 1/3 of the population of teenagers are pregnant in the last 3 years. So we have a big issue with teenage pregnancy in our country. this is an important fact. If you can see the last bullet, 10% of the teenagers, the teen girls who have been sexually active in the last year have had sex with a man 10 years older than these girls. So I always remember the story of a girl when maybe 5 years ago, she was 11 and delivering a baby. And I started talking with her. Why are you pregnant at 11? What happened? Oh, I left my house when I was 8. And why? I cannot imagine leaving my house at 8 with a man and start having sex with a man. And she told me there was no food in my house. So he offered me food. And that's why she left her house and the security of her house, because it was a mouth, one less mouth that her parents have to feed. So he got pregnant when she was 11 because she hadn't had any period before of that. So that's the reality of our countries. Girls are given themselves to men because they don't have anything to eat in their houses. I know this is in Spanish, but I just wanted to share the global fertility rate trend in our country. And it's very interesting. The first column is from 1987, 1995, 99, 2002, 2009, and 2015. You can see the difference between urban and rural people. Women were having 4.1 children, every woman. In rural area, it rises to 6.5. But now this is much better, from 4.1 to 2.5 and from 6 to 3. But I want you to see two very important numbers here. From indigenous versus non-indigenous, from 6.8 to 3.6, and non-indigenous from 5 to 2.8. So you can see that we are very, we're not a fair country, because we don't have the same opportunities if you live in the city or if you live in rural areas, and if you're indigenous versus non-indigenous, and if you have education or you don't have education. People with education used to have 7 children per woman, and women with education 2.7. So the difference is huge. We're not a fair country, because if you're poor, indigenous, living in rural areas, and you don't have an education, you have more, it's more probably that you have a lot of kids and you die during childbirth too. This is an interesting data. In blue, you can see the percentage of women using a method, any method. It rises from 22 in 1987 to 61 in 2014. But this number is way much higher in urban areas compared to rural areas. Rural women used to have a method only in 14% of women in 1987, but it rose to 45-50% in 2014. This is the last data that we have. We don't have any recent data. The average of first birth, it's about 20 years old. And there has been some international writings, interesting international writings about Guatemala. In Center for Reproductive Rights in 2003, they did this extensive, and I put it here if you want to read it. It's in English, so it's easy to read. It's interesting what they stated. The government obligation to ensure access to family planning information and services for all citizens, and it said what is this about? So every couple and every individual should have access to family planning services and information, as well as established under international human rights. So Guatemala has signed international laws that we're gonna see a little later. It consists on that they should have access to both health, that includes reproductive health, because reproductive health and reproductive sorry, I forgot the word. The rights, reproductive rights are human rights. We cannot start saying that women should not have any kids because we're too many in the world and population. I'm sorry if I know a lot of people think like this, but today I'm gonna share with you a different perspective. Yes, let's stop having so many kids, but from another perspective, with respect, with rights-based decisions that we're gonna talk a little bit later. These rights are explicitly articulated in human rights treaties and instruments that Guatemala already signed, as the Universal Declaration of Human Rights, International on Economical, Social, and Cultural Rights, Convention on the Eliminates of any form of discrimination, racial discrimination, and rights of child, and other ones like American Convention of Human Rights, and Inter-American Convention on the Prevention. Then IPPF in April 2014 made this beautiful fact sheet if you want to look at. I just put some specific bullets here. 11% of our population in 2014 were anywhere between 15 and 19 years old, and 40% of them were indigenous. Indigenous people are more in risk of malnutrition, poverty, and extreme poverty. They don't have access to education, to health, quality health system. Half of them are sexually active, but not married. And 26% of them, they don't have access to any contraception. And they don't want to have kids, but they don't have access. So in WINGS, the NGO that I work with, we provide services, IUDs, hormonal implants, shots, hormonal shots, pills, condoms, to girls from 14 years old up. And this has bring us to a lot of troubles, because a lot of people said that we should give these methods only for women from 18 and up, but that's not true. Our constitution allows us to provide them from 14 years old. They also tried to include in 2010 the prevention through education declaration that in the last 2 years have been in a lot of trouble, because in the Congress there's a lot of people trying to bring all this down. I'm going to tell it later. Legally, minors are required to have parental consent to access HIV testing, so we cannot provide HIV testing to minors. Abortion in Guatemala, and I want to put emphasis in this, abortion in Guatemala is severely restricted and is legal only if the mother's life is in danger. There's no other way that we can provide abortions in Guatemala. So just last week, a woman in Escuintla, in the south of the country, went into a hospital bleeding. So when the doctor made a test in her, she found misoprostol, the medicine to provoke abortion, and now she's in jail. So the doctor called the police, and the police came into the hospital and take the women into jail. So it's a huge fight that we are having, because they were not even treating the women. They were only treating the criminal act, and it is pretty awful. Restricted legal access to abortion often leads to unsafe abortion practices. We don't have official numbers, but a kind of 600,000 unsafe illegal abortions are happening in Guatemala every year, and it's the third cause of maternal death, and Guatemala has the highest maternal death in Central America and one of the highest in the world. And it has no logic that women who are getting an abortion, they're getting it legally or illegally. and they're dying because it's not legal. And we have been working, trying to legalize it, but it's something very difficult, and I think it's not going to happen, at least in the next 15 or 20 years. There's a lot of interesting things that you can find in this fact sheet. I'm gonna pass it a little bit. Okay. So in 2014, with the help of USAID, they did this compendium of laws related to family planning in Guatemala. I just want to mention it. In 2001, social development law. 2002, the policy of that law. 2004, and this is very interesting, the alcoholic beverages tax law, that every time someone takes a beer in Guatemala or whatever beverage with alcohol, 15% of the cost of the beverage goes to family planning program in Guatemala. So that was a big win. In 2005, the family planning law finally was written and socialized. The name was Universal Access to Equitable Family Planning Services Law, and it's beautiful. If you can read it, our laws are beautiful. So one day I talked with a lawyer, and she told me Guatemala has one of the better and greatest laws written, but not in practice. So in 2006, the national budget was finally established for family planning programs. In 2009, the ruling for family planning program was established. 2010, the Healthy Motherhood Act was written, and it allows to provide more counseling and family planning methods in the postpartum, in immediate postpartum. And in 2010, this is very important, they make changes in the purchase laws to provide the country with enough family planning methods, IUDs, hormonal implants, and all the kind of methods. So we have this beautiful look at the faces, everybody laughing, everybody's happy, and we have beautiful paperwork, but we're not, we don't see it every day in reality. Another Guatemalan legal framework that it's important to share with you here, law against sexual violence, law for the comprehensive protection of children and adolescents, and the general law to combat human immunodeficiency and HIV. So what's our main or current difficulties right now? For me, the first of all is that the Congress have a majority of conservative legislators. So they are seeking to eliminate comprehensive sexual education in the educational system. So they don't want us to tell our children and our youth how to prevent pregnancies. And they want to stay saying, don't have sex. And that doesn't work. So it's a huge fight there. They also want to increase the criminalization and criminal persecution of abortion for patients and for providers. So that's another big issue. And they want to reduce access to contraception method for minors. So by law in Guatemala, if you are under 14, you cannot provide permission or consent to have access. Any sexual intercourse beyond 14, it's considered sexual violence, and we cannot provide any contraceptions, any. Once they're 14, we can provide whatever they decide, except surgeries. You have to be 18 years old to drink and to have a surgery and to vote. Another one is the lack of political will to comply the beautiful existing legal framework. But I think this has been changing, and you can see the numbers, how the women have come from having 7 kids in 1987 to having 2 or 3 right now. So it has been working. And third, and for me, the most difficult to work with is local myths. So people think that the IUD is going to be in the front of their children, or cultural, linguistic, and religious barriers, not only with patients or women population, general population, but also with providers. Because in our experience, we have provided, for example, a hormonal implant for a girl, a 17-year-old girl, and she goes with a doctor, a private doctor, and why did you let Wings people make that for you? You're gonna die. And they take out the hormonal implant. So we have to fight with the government and with the patient sometimes, and with providers, because there's a lot of misinformation and religious confusion. They say sometimes, oh, in Wings, they're abortionists. Abortionists? They do abortions. And we always have to say, no, abortion is something. We are working family planning. We don't want you to get pregnant. We're not doing abortions. And that's something that we have to regularly say to open doors and make people accept what we are offering. So this is our beautiful nurse, Ellie. She's walking from, you can see at the back, the truck where we put everything in, and we go to schools, and we go to houses and community spaces, and we put on a pop-up clinic. So we're having everything in our truck, and we try to get to that place where nobody goes, where it's difficult to have access to information, to counseling, and to methods. So Wings services are rights-based approach, and this is where I want to make a little stop. It's easy, this speech that we always have, that we have to stop so many kids in the world, and you should do tubal ligation to every woman and every poor women. Oh my God, that's so not respectful and not based on her rights. Of course, I want that women to stop having kids, but it's not my decision. So I always say to my nurses, even if you see a very skinny, poor woman with 10 kids, if she doesn't want a method, you don't give her a method, because we have to respect her will, her decision. But they haven't had access to information. So that's the clue for me. It's their choice, but if they have good quality information. So quality counseling and access to qualified services is the base of rights-based approach of providing these services, because it has to be their will, not ours. We can think something, but at the end, it's their life, it's their decision. My obligation is to tell them, if you have so many kids, how are you going to feed them? How are you going to send them to school? You can die giving birth. So I can give her the scientific facts and all the methods that she can have: hormonal implants, IUDs, tubal ligations, shots, pills, condoms. My obligation and the obligation of Wings staff is to provide information in a way that the people can receive it, because I don't expect my nurses to stand in front of women that haven't even studied ever in her life and talk like very professional. No, we have to talk in their language. We have 22 indigenous languages. So if I talk in Spanish, they're not going to listen to me. So what we try to do is to find an translator, and we try to use their clothes. For example, some of our nurses are indigenous people from the places. So I ask them not to wear these jeans and t-shirts. No, I ask them to wear the indigenous clothes and maybe something else just to try to be professional. But this gains the trust of the people. This makes us be more approachable to them, and they listen to us. So if we give them the information with responsibility, with their language, easy to understand, they are gonna get it. So we don't have to push them to choose a method. We have to push them to understand what we are saying so that they can decide. So this is where we are actually giving services this year. In blue, you can see all the departments that we are focused right now. We're trying to give services in the most indigenous, rural, poor places where we know there's a lot more of need. Petén, just in upside of the country, it's too big, so we haven't been able to provide services there because it's extremely big and the population is small, so they're very, I don't know how to say it, a little here, so it's difficult to provide services there. But our goal is to be nationally. Right now we're almost nationally, but it's a kind of resources thing too. So this is how we work. This is the truck that travels throughout half of the country. We have right now 4 trucks that provide services. And I love this picture. She is a youth peer educational program participant, and she's so beautiful with her. What she says is, I am committed to know, to defend, and to promote the rights of children and teenagers. So she's not saying, I am going to talk to every kid I know that she doesn't get pregnant, or that she has sex and liberal sex, or she doesn't have sex. No, she's talking about sharing the rights. So we should, when we talk about rights, we're talking about decisions. We're talking about making women and men strong in their decision, in their own knowledge, and making them able to decide instead of deciding for them. So this is what I prepare for you. I don't know if you have any questions. We can go.
Thank you so much, Michelle. That was great. Really, really so interesting always to learn about the super important work being done by WINGS and about the rights-based approach to care. We're going to open it up for questions. So again, if you do have any discussion points or things you would like answered, please feel free to voice them in the chat. We're going to keep everybody on mute though, as we have Natalie and Stephanie helping us field questions. Our first question is from an audience member who says that he is really pleased to learn as well about the bottom-up rights-based approach that WINGS utilizes to distribute family planning services throughout the country. And the question is whether in Guatemala there has been a history of top-down coercive population control measures that have been seen in other parts of both Latin America and the world, particularly before the 1994 population conference.
Mm-hmm. I think not directly, but indirectly, yeah. Mm-hmm. So we have talked to a lot of women who had tubal ligations with other institutions years ago, and they are searching for us, telling us, can you please unwrap, or how the world you say, can you take the ring off because I want to be pregnant? No, that's when we explain them, a lot of them start crying because sometimes they haven't been explained, but not as a law or as a regular thing, but more as misinformation thing.
Mm. Yeah, I was noticing in your presentation that you talked a little bit about the family planning law that was implemented that seemed pretty progressive, but you were saying that it wasn't something that had necessarily been implemented. And I was wondering if you could kind of expand a little bit on that, because while many politicians, excuse me, might disagree with the law, it still remains a law, right? So are there repercussions for that? And similarly, I was going to ask a follow-up question just about the kind of culture related to abortion services and reproductive health care, and whether or not that's a big focal point for politicians who are campaigning. Certainly is in the United States. So just curious what it's like in Guatemala.
I'm going to start with the last one. Politicians use a lot of the, I'm against abortion. That's the main, because I'm a son of God, and God is putting me in the land, all this, how do you say, populist?
Yeah, populist.
Because they want to gain people with Catholic and evangelical people, and that's not true. They're not gonna do anything of that, so they use it a lot for their own will, and with not providing or not accomplishing the law. I have to say, for example, the law says that if you're 18, even though you don't have any kids, you can have a tubal ligation or a vasectomy. So we provide those services, but we try to give more counseling. Are you sure this is forever? And we take some time, but if they're decided, we do it. Even though if they don't have kids, even though they don't have the permission of the partner. But I think we are the only ones in Guatemala doing it right now, because the Ministry of Health and other institutions, they ask people to have at least 2 kids and to have 24 years and to have the sign of the partner. And that's illegal, but because the law says that they have the right to decide. Other thing is that the national system, the public system, they don't have enough people trained to do vasectomies, tubal ligations, IUD, and hormonal implants. So people are looking for the services, but they are denied because they don't know how to do it, or they don't want to do it because of religious. And that's something that helps, because sometimes we come and put a pop-up clinic that we set up in a school, for example. So we put everything, provide the services, and then leave. And a lot of people like to come with us because they know the nurse at the health center, and she is the cousin of my husband, and my husband is in the US, and now I have another partner. So I don't want that nurse to know that I'm using a method. So that helps sometimes, that we go provide the services and leave, and so they don't care who is providing it. But yes, they are not doing what the law says because they don't have the people trained or the resources.
And so that's basically where you guys come in. So one of the other questions is asking what your relationship is with the government. Obviously, there are these family planning laws in place that aren't being implemented for a variety of reasons. And so do you guys work with the government? Is the government on board with what you're doing? Or is it contentious in any way, or how do you guys work together?
Yeah, after 3 years of trying to reach them and talks, and it was pretty difficult, we finally signed an MOU. It's time MOU with the Ministry of Health, and that opened for us every door that we try to reach right now. So yes, we have to be respectful, and that's something that I've learned, that we have to be. It's not, how do you say, hypocrisy. It's not that. It's being educated and being respectful of authorities that allows us to provide more services and to provide better services, because we don't have the money to set up hospitals in every department. So we have to use their hospitals. We bring everything, we use their hospitals, do the tubal ligations, vasectomies, maybe perform 25 surgeries in a day, and then we leave. we wouldn't be able to do it if we don't have that communication with them. So it's basic, it's essential.
Right. Wow. You guys are certainly filling a gap there with regards to giving people access to unmet needs for family planning. So that's fantastic. And I'm sure that the sort of lack of government involvement overall is a contributor to this. But I was wondering about teenage pregnancy. You mentioned in the beginning of the presentation that in Guatemala, it's among the highest in the world, and it's actually increasing. So I was wondering if you could kind of touch on that, as well as the wide disparities in urban versus rural uptake, and why that is as well.
What I just saw in the national national maternal and women's study is that for youth, it's the same amount of girls that don't have access for family planning methods, even if they're poor, if they're rich, if they're living in urban or rural places. And it's something more related to education, probably, and to the myths that you have to wait. Guatemala, it's very different, for example, from the US. I have spoke with a lot of US people, and they all leave their houses at 18 and they live with a boyfriend. In Guatemala, no, you have to leave your house wearing white when you get pregnant and married, and you don't have sex before marriage. That's what people said. That's not what is really happening. So girls are having sex, but they are not allowed to ask or to talk about family plan or contraception. So the difference is that rich girls have access to abortion because they travel to the US or they travel to Costa Rica or whatever place. Poor girls died because they put some umbrella sticks they in their vaginas. So I have seen at least 5 girls dying in my hands, and it's pretty sad. And maybe one of the huge why I work in this, when I was a student alone in a health center, a little girl came in and she was crying and she was so bad. She was maybe 13 or 14. And after talking and trying to know what was happening, she told me, finally, I'm pregnant and I don't know how it happened. And for us, everybody knows how you get pregnant. No, our little girls don't know how pregnancy begins. So with my very bad education as a physician, I told her, well, I'm sorry, there's nothing we can do. Good luck, here's some vitamins and see you in a month. And the next day, I found out that same afternoon, she hung from a mango tree in her house and she died. So this is reality, and she doesn't appear in any graphic, in anything. So women and girls are dying, and we are denying the possibility, the opportunity, not only for abortion. Abortion is another thing, but we're denying the possibility of preventing and pregnancy and unintended pregnancy. So for me, it's that we have to educate and we have to provide services, and we have to give a different kind of services to youth, because it's different approach, and the services that we provide, it's different for women, 25, 30, 40 years old women, than for a 16-year-old girl. We have to treat her different. We have to use, for example, how do you say, social media, social redes. For us, Facebook has been one of our biggest allies to promote our services, and a lot of women and girls are writing us in Facebook and please help me. What can I do? So we have to use whatever we can to provide counseling, quality counseling, not, oh, I think you need to have a tubal ligation, because that's not quality counseling. Quality counseling is saying, these are your choice, your options. What do you want? So we have to change our, not only patients, not only regular populations, but us providers, because we are the first barrier to provide quality rights-based services.
Yes, that well put. It's that story is just heartbreaking about the girl, and I think it's something that you know, as devastating as it is, needs to be highlighted and emphasized as the reality on the ground of people and communities and populations being denied access to family planning and to abortion services. Just never really understood why just the basic stats behind what happens whenever you restrict abortion versus whenever you don't aren't better understood by people who are sort of ideologically driven politically. But it's obviously a big problem everywhere, including in the United States. And unfortunately, it's very much a factor of socioeconomic class at the end of the day. I was wondering, with regards to teenage pregnancy, we've been talking a lot about that. And we've also seen this sort of massive influx of migration as a consequence of climate change. And in other places, like in the Sahel region, which is where we're going to get to later on in the month, there's a lot of documentation recently on the rise of teenage pregnancy as a consequence of climate change, because as subsistence farmers and sort of rural populations are unable to you know, produce food in the same ways, marriage at earlier and earlier ages becomes more advantageous, if I could even use that word. So I was wondering if you could kind of touch on the links between migration and climate change throughout Guatemala and some of the climate impacts that are impacting the populations you serve.
I'm not sure if climate change is the first, definitely no, it's not the first cause or the first reason why people leave Guatemala and go to the US. I think it's violence, because gangs and poverty and extreme poverty and food security, but it is all related, right? We can't deny that we don't have enough access to food. Half of our children, 51% of our children under 5 are malnourished. They have malnutrition. So definitely it has something to do with climate change, and more frequently little events are happening in Guatemala. For instance, last year we have a small hurricane, but it made a huge disaster in some departments. And some people that I know already left to the US because they lost their houses and they lost the little land that they had to feast, how do you say it? To the corn that they eat. So I don't think that we have official numbers, but definitely it's something that we see. People leaving because they don't have anything to eat. And because of violence. That's the main reason people are leaving. So yeah, being a little selfish maybe, or not thinking big, but thinking individually, it's sad. It's pretty sad that every woman are having too many kids, and they have 10 kids and 5 of them die because of malnutrition. So I see it more individually, not as a country or as a world, but definitely we have to do something, because food, it's not enough for the world, and gas, it's not enough for the world, and all the resources, natural resources, what do we think? That natural resources are gonna multiply? No, they're gonna finish. So we have to be responsible. And share that responsibility and that information with people with that hasn't had the luck, they haven't been lucky enough as us that we have possibility and education, and give them this information, because it's not their fault not to know it. It's our fault not to share it.
Absolutely. And kind of dovetailing off of that, there's a question kind of looking a little bit more in an environmental context at the consequence of natural resource depletion and an ever-growing population with regards to the Earth's biocapacity or its ability to regenerate resources over time versus how much is being taken out. Obviously, the continued growth of the world population is sort of driving this. It's one of many different drivers, but one of the questions is just asking what your opinion is on world population growth and the world already being in what's called overshoot or deficit natural resource wise.
Mm-hmm. I think yes and no. Maybe some people are not going to like my response, but I think, yes, we have to stop the overpopulation, and we have to stop having so many kids, definitely. But we also have to work in a fair distribution of the resources, because I think that the richest countries and the richest people, they're throwing food every day, and the poorest people in the poorest countries, they're starving to death. So there's something there that doesn't sound logical or fair, or I don't know what's the word, but we have to work both parts. Yes, stop growing the population, but also we have to work in the distribution of the, how do you say it, the money, the resources.
Yeah, no, absolutely. And I'm sure that most people, hopefully everyone on this call would completely agree. Population and environment should not be looked at linearly or in a myopic way, because it's a very complex issue. And a small amount of the world population consumes the overwhelming majority of the resources, while in other parts of the world, like in Guatemala, people are literally having to leave their houses as a consequence of climate impacts and climate disasters, for which they're not even, very culpable in comparison. And it's creating these humanitarian crises all across the world. So I'm really happy you pointed that out, and I think everybody is kind of on the same page there. Another question is just asking about WINGS in general as an organization. It was really great to obviously hear so much about the work you're doing. And I guess you guys just had your 20th anniversary, so congratulations. And one of the questions is just asking what are some of your major goals that you hope the organization will reach in the next year and 5 years?
Mm-hmm. So we are trying to do like, how do you say, in order growth. We don't want to grow like crazy. We are trying to do it very in order and with regulations, because I don't want to lose quality. So every time we hire a nurse, we nourish her for 3 months, and unless we are absolutely sure that she's able to provide quality services, we don't allow her. So my personal goal is to continue that quality services focus, to provide quality services to poor women, or to women that doesn't have any access in other way to quality services. And in WINGS, we're trying to rise and provide more services to more women and men, and geographically, to grow geographically.
Great. That's quality over quantity is always the best policy. So that's fantastic.
I always say, I don't want you to put 100 IUDs and have 90 perforated women. I want you to put one, but a very good one. So we're very focused on people doesn't have, it's not their fault, they are poor. and they cannot pay a rich doctor in the best hospital of the city, they should have the same quality service in the little village where nobody goes. So that's my main goal.
Fantastic. And with regards to the youth leadership program, I think that's another really great facet of your organization. And I was wondering if you could just tell the audience a little bit more about that particular program and how it's been able to carry on or not during the pandemic, and kind of what the future looks like post-pandemic era for Wings.
So our youth program, it's providing education to 50 youth leaders from 13 to 19 years old through 1 year. So we teach them how to be confident with them, and when to decide to have sex, and how to prevent sexually transmitted diseases and pregnancies, and when they have all the information, how to replicate it with their peers. So the main goal is to give information to as many youth or teenagers as possible, so they replicate it in their houses and in their villages and in their schools. With the pandemic, it has been our better program. How to say, what better changed? Because I'm not good with how do you say, with Facebook, and I'm too old for that maybe. But the teenagers, they want to use their cell phone for everything. So we changed the program, and they are receiving it virtually, and it has worked incredible. The result has been so good that this year we've been able to change it and include teenagers from other regions, and not only from where our office is. So it was a big opportunity to provide services and to provide the program to other regions. The only thing is that they haven't been able to replicate it because schools have been closed and we cannot gather people as we used to do. But I think it has been a huge experience of how bad things bring us to good things and to good changes.
Yes, yeah, definitely. It's such a important and I think impactful program to be educating youth and to be really normalizing the process of accessing quality, comprehensive reproductive health care. As we're kind of finishing up here, there's a couple more questions just at a more sort of country level macro scale. And obviously, as an organization, Population Connection has been working for a long time on rescinding the global gag rule, which I assume, because abortion is illegal in Guatemala, doesn't apply to you guys anyway. And I feel like that's kind of the trend throughout Central and South America for the most part. There's pretty austere restrictions regarding abortion. And yet Argentina just recently was able to legalize abortion democratically. And so I was wondering if there was any reverberations throughout Central and South America that might sort of spearhead this initiative in other places, or if it's kind of expanding the cultural acceptance of reproductive rights or abortion, or what?
I don't feel that abortion is going to be an option, a legal option in the next years. It doesn't look like. Argentina was a big example, but here everybody is using Argentina example as we don't want to become Argentina. So politicians are already saying that if you don't want to be Argentina, vote for me. So no, I don't think. But family planning, it's getting more and more acceptance. So one little step at a time. I think we have to be patient and continue working.
Mm-hmm. Yeah, it's interesting because I would have thought kind of the opposite, but perhaps it has something to do with the disparity in rural to urban populations. Is it mostly rural in Guatemala? Obviously, there are many different indigenous groups and many different active languages and sort of cultures.
Yeah,
But
we have
what's the disparity? Oh, 22, yeah.
we have 22 indigenous languages, and every language has like 10 variant, 10 different ways of talking. But there's something very particular that in the rural, how do you say, not rural, urban, sorry. The urban region, it's getting more and more poorest. So at the beginning, Wings used to provide services only in rural areas, but every time we were looking more and more people living in extreme poverty in urban areas. So poverty is migrating to the urban region. And we don't have to forget that there's poor people and people without access to education and to health services in both sides. The difference is that in the cities, you have it very close. So if you try, you can find things. In urban areas, our streets, streets are very bad. So there are places where you have to travel 100 miles, but it takes you 8 hours. Yeah. So anybody says 100 miles, it's not that much, but 8 hours to get it, it's difficult. And sometimes there's only one bus to get in and one bus to get out. So there's a lot of difficulties, topographic difficulties that put some special difficulties in people.
Yeah. Yeah, well, thank you so much for expanding on the work that WINS does and for your organization overall for providing direct service in a place that wouldn't otherwise, facilitate that service at all. So you guys are undoubtedly doing such important work. It's 11:59 my time, so we're gonna finish up here, but I don't know if there's any final thoughts you have, or if there's one thing you would want the audience to know about WINS or Guatemala or the state of reproductive rights before we close out here.
Yes, I just want to everybody go leaves this session thinking different and try to put your mind in other places, because sometimes we only think one way and there's 1,000 ways to reach for solutions. And don't forget that reproductive rights are human rights and we have to fight for them.
Absolutely. Thank you so much. In the chat here, you're getting some accolades already for such an amazing talk. So thanks for being with us. We're such proud partners, and yeah, we'll sign off. Thanks, everyone.
Thank you.